And okay, so that's the transurethral resection. Now I think I may have a couple of minutes. I'll just go briefly about. This is kind of a different. This is taking out the prostate. This is robotic prostatectomy. I'm going to show you that. So it's still relatively minimally invasive, I suppose, under the big heading of minimally invasive therapy. But this is removing the prostate through different incisions. Now this is just the slides from the company, the Intuitive. That's a company. The machine is called a Vinci robot. Somebody was speaking with me earlier about Dr. Menon, Monty Menon, who's from Henry Ford. That's originally kind of, he really a big proponent. He wasn't the first one who did them, but he was a strong proponent and really got it going and popularized using the robot for prostatectomies. The idea is that it's more like a hand in terms of your fingers and how you can actually manipulate the instruments, different like the wrist motions and so forth. There's no hand tremor, and you can actually magnify it. You see, here's the actual lens that we put inside the abdomen, and it got two cameras, two lenses, so it basically gives you a three-dimensional view, 3D vision, and the physician, the surgeon sits at the console, kind of like this, over here, and working like that, and working on the instruments like that. Have another surgeon by the bedside helping out with changing the instruments and so forth. It's still a little clumsy, but it's certainly right now is quite a slick procedure setup. But still, here it is there. That's me doing the procedure. This is blow up with the hand control, and then the other surgeon by the bedside. The instruments are put in the abdomen first, and then the robot gets hooked in and connected up. Now, I just want to show you this. This is from the company, from the Da Vinci U.S. U.S. Da Vinci system. I got the slide from the company. This is the number of units. In Canada, there are about, I may be wrong, maybe 13 units right now in all of Canada. This is in the United States. Okay. In 1999, there were a couple of places here. You see that? You see the dots there. And then they started putting them in. Year 2000, 2001, 2, 3, 4, 5, 6. These are a number of units. Da Vinci, this is robots. 7, 8. What's that? Raindrops. 2010, 2011. 2012. So there are that many units within the United States alone. Okay? Oh, sorry, 2013. So in Canada, I was saying we started, actually, I'm proud to say that we had one of the first units there. We did the first prostate, but still there are only like 12 or 13 units in all of the country. Aside from prostate, other systems, head and neck cancers, they can do that. They can use that. The cardiac surgery, some people use that, and gynecology, they're doing, and even some general surgery. You can do a very fancy gallbladder removal with a robot, I suppose, and some people actually have done that. So here's a number of places that are using the robot. Different hospitals. So some of you are near here. Humber River Regional Hospital has one right now. Okay, well, actually, we published the first series from Canada with so in one of the journals, and the editorial said, "Fools rush in." So was I a fool? Or early bird gets the worm. So that was the editorial. Actually, my colleague Laurie Klotz said that. So actually, the jury is still out on this. You know, or it's actually much more beneficial. Even so, that was quite a while ago, and this is more recent. In another editorial, the rise of the machines, or is it Judgment Day? So the debate continues as to whether it actually is beneficial. I'll just show you very briefly a clip here. This is what I actually see, what I'm actually controlling. I'm burning a little blood vessel right there. This would be like 1 minute. Just to show you, the whole prostate actually sits around there. This, of course, is compressed. It would have taken me quite a while to get to this stage. Okay? And you can see it's pretty dexterous. You can both right hand and left hand, but the instruments have to be changed. Now, I won't bother trying to orient you as to exactly where we are, but just to give you some idea where things are in terms of using the scissors here and cutting, and in terms of the so-called nerve sparing, I guess most of you are familiar with that, we can do nerve sparing just as well, if not somewhat better, but it really depends on the person or the surgeon recognizing the anatomy, exactly where things are. And also in terms of incontinence, now here's just dividing the urethra now. Here's the urethra, the prostate is back here, so we're almost there in terms of detaching the prostate from the urethra. You'll see that in a minute. So here's the prostate, you can move it. It's already been moved around. And just, this is the urethra beyond that, we're just showing. And I guess I'll just move it along a little bit here for you. Okay, so now you see the catheter. There's a catheter, so we're going to take that out, and the prostate is going to be out. Now, it'll still be inside the abdomen. We still have to take it out. That's why those of you who had robotic prostatectomy, you actually have to, we enlarge one of the small incisions by the belly button to take the prostate out. Now here, the catheter has just been slid out. See that? So just disconnecting the very last bit of connection here in the prostate. So there, that's out, and not out, but it's totally detached. And there's the organ. And then you see here, we actually have like a net or bag to catch it. Put it inside a plastic bag, just like that. I guess you can relate that to other activities that you're doing. And then we take the bag out later so that when you're squeezing and pulling, it doesn't get squeezed out and so forth. So that's that. Okay. And then, now it's not done yet, of course, there's the urethra. The bladder is up here, so we still, in this case, we still have to connect the urethra back to there. And that's the next step in this procedure. Okay, so, nope, I'm sorry. So that's the end of that. The limitations there are, obviously the robot is very high cost. It's up to about $3.5 million now. And then there's the operating cost, annual maintenance fee for the kind of the maintenance contract. Disposable instruments, there are this throwaway instruments, non-reusable. For each case, it's fairly substantial. It's like $3,000 per case, over and above what you would normally spend, the hospital would normally spend for doing, say, an open prostatectomy. And then, of course, there are the training costs for the staff, for anesthesia, for other things. And not every patient is a candidate for robotic surgery. These people wouldn't be, just because even the instruments aren't quite long enough. And there are challenges. For someone who has had multiple surgeries, and there would be a lot of local adhesions inside the abdomen. But, sometimes you can still try to do it, but it becomes much more difficult, and sometimes it's dangerous even, because the bowel and other organs are stuck in different ways that you don't expect, and you can injure them more easily. Someone who's had breathing problems is not a good thing, because actually, I didn't show it to you, but the table, during anesthesia, the table has to be tipped way up so that the head is way down, and the legs are way up, so it's not good for breathing, for the anesthesia. if the cancer is very advanced, for example, here's the prostate, but say the red was the cancer and is extended further away, that again is not a good candidate for, not a suitable candidate for robotic surgery. So that's, in a nutshell, it's basically, I'm not going to show you any results or anything, but basically robotic surgery has come and is being done in lots of places within Canada, and I do that. I actually still do both open and robotic surgery. Some of my colleagues just do robotics, and some still just do the open procedure. And I choose, different patients. Of course, patients have some preference, but I tell them, obviously, individuals like this wouldn't be suitable. But then there are other individuals that they just pick what's based on their preference. So, that's the lung I mentioned. For bad lungs, and chronic smokers, and so forth, it's not a good thing. My last slide, kind of a quiz. What are these people talking about? Well, some of you think you know. Of course, we talk something urologic. Some of you may have had that. So I see Colin Powell here. And there's Condoleezza Rice. Okay? But there's an old slide. Anyway, so again, I hope I've covered most of the areas that you wanted to hear. Again, I want to thank you. I want to thank Jansen for the support, and of course your three groups getting together and having me here, and thank you for your attention. I'd be glad to answer some questions for you.